So, good evening, friends. All those who have joined on the platform, welcome to this seminar. As you know, many years back, we used to do what we call WhatsAppinar. That time, we didn't know about the Zoom and other online platform. This is much before COVID.
Oh,
So we used to type out question on WhatsApp, and people will the experts will answer and back and forth.
okay.
From there, then we went during the COVID time to the Zoom platform, and then we had lots of webinar. And I remember vividly the COVID webinar that we did on the WhatsApp group of Gujarat with Dr. Bajania, myself, and many others. So after that, of course, the physical meeting started. So we also did not do much. But then now we are back because I think people want to know about online sitting in their own home. So we are back, as we said, Gujarat Pediatrician WhatsApp group webinar. First of all, as we all know, there are more than four Gujarat Pediatrician WhatsApp group, all ably run by Dr. Ramesh Bajania. So I'm very happy that we have started this first season. Now we are going to have on first Thursday of every month, same time 9 to 10:30, and we will have different topics. And we will come back very soon with the next program as to what it will be and who will be the faculty. Now, before we actually start the talks, I would like to introduce Dr. Ramesh Bajana because he's going to be the moderator, and then after that, I will ask Dr. Trambak Datta from Zydus, who has helped us with the support of this web stream program and the platform. But before that, I will just say that, as I said, Dr. Bajania is the brainchild behind the WhatsApp group that he started, where a lot of pediatrician on a day-to-day basis ask for a very basic question answered by people from around. So it's like a group learning. He, of course, has been the IPEB member for last three consecutive time. He has been the chairperson for the environmental and child health chapter, which is doing some very yeoman work. Especially, he is now leading the India lead poisoning group. So I think that's very good that Dr. Ramesh Bajana is very active in the environment and child health. And of course, he's a very dear friend of mine. So now, before we hand over the mic to Dr. Bajania to carry forward today's question answer, I will ask quickly Dr. Trambak from Zydus to say a few words about Zydus, and then we will start our scientific session.
Thank you so much, sir, for this opportunity. We would like to extend a thank you to all the pediatricians of Gujarat for this opportunity. This is an educational initiative supported by Zydus. I am Dr. Trambak, medical advisor for vaccines. And I will just run you through the Zydus corporate presentation very, very quickly without taking much time. As all of you are already aware of, the purpose, mission, and vision of Zydus is to be a global life sciences company transforming lives through path-breaking discoveries. And we are a well-integrated pharma player with a proven track record. Over 23,000 people impacting lives across four continents. And Zydus's innovation-driven, rich pipeline is always there with, supported with 300 plus generic products, 20 active discovery programs, and more than 1,400 research scientists. So there are various kinds of drug discoveries which we have made and which includes monoclonal antibodies, nutraceuticals, wellness products, controlled substances, NCEs and NBEs. And launching products with that address the unmet healthcare needs has been the mainstay of Zydus. We have NBEs and NCEs like Lipaglyn, Exemptia, Vaxiflu 4, India's quadrivalent influenza vaccine, Finrab, Bilipsa, and we have also had launched Zycov D as well as Oxemia in the renal healthcare. So, creating value as India's leading consumer wellness company, our R&D and development capabilities are well known. So, I will just run through the various vaccines which we have launched: the typhoid and Hep B, Vaxilla N, we acquired Itna Biotech in Italy in 2008, followed by Vaxiflu S. Vaxiflu 4 is India's first quadrivalent and indigenous influenza vaccine, and then followed by launch of the division Vaxicare, Zyvac TCV, the typhoid conjugate vaccine, Twinrab, Zyvac MMR, and so on. And finally, we have also launched this time again for the third time the SH strains ahead of other brands in the country. This is for the third consecutive time. And Vaxiflu 4 does have now the latest SS strains as recommended by WHO. The Vaxiflu 4 is now also having the 25G Terumo needle, which is an upgrade from its previous needle. And this basically embarks Vaxiflu 4 on a great innovation journey. So it is an indigenous product at the forefront of protection, which is guarding 1 million lives in 2023. So I personally have taken the asset strain few days back, apne flu vaccination liya kya. So these are the initiatives of Zydus Vaxicare, the VCare initiative, the brand Vaxiflu 4. Zyvac-TC Twinrab is world's first novel cocktail of monoclonal antibodies. Our Viram initiative to end rabies by 2030, Typhoid Doesn't Discriminate initiative, and Fluxination initiative. Thank you so much. Over to you, Dr. Ramesh and Dr. Nitin. Thank
So
you so
thank
much.
you, Triambak, that for a very lucid and a very quick update on what's happening. And I'm sure all of us know during COVID time, mRNA and DNA vaccines were used for the first time for human beings. They were there in the armamentarium for many years, but they were actually never used. So I think now we have a ready-made DNA platform. So while ZyCoV-D may not be required today, but the DNA platform will be required for some vaccines which are going to come. Someday I will speak on future of vaccinology in some forum. Then I'll tell you about
Sure, sir.
plant-based vaccine. There are what do you call probiotic-based vaccine. There are needle-free syringes and needle-free injectors, and I mean unbelievable journey about vaccine. So, but that I will reserve for some other day. Now we start our today's program. That is the first session of this We Are Back series, and today the topic is something which is very dear to my heart. That's my profession, hematology. So I chose my profession over my passion some other time. So we are going to discuss the laboratory aspect of hematology. And I think Dr. Ramesh Bhajania will take it forward through the question answer session. And in between, if you have any question, do please type it out and send it across, and we will try to cover them. Over to you, Dr. Ramesh Bhai.
Yes, thank you, Nitin Bhai. So thank you, Zydus, for all the support. I created this group in 2015.
Ramesh Bhai, your audio is again a problem.
I created this group in 2015, and we, as Nitin Bhai said, we were pioneer in online seminars and webinars. In fact, COVID current perspective webinar was viewed live by 1464 colleagues. The aim was basically to help the colleagues. And where does this help come? I mean, it comes from the friends only. And there are faculties, there are subspecialty experts. And I'm thankful to all of them for helping our colleagues day and night. Thank you, Dr. Nitin Bhai, who hardly needs introduction, but still, he's a section head.
Next, Viva.
So, I mean, it's very cumbersome, I mean, to introduce you in a few minutes. In fact, Dr. Vibha sir was very, supportive that let us take Vibha along with us. She's the assistant professor and in charge pediatric hemato-oncology at
Sir, only one introduction that I'm student of Dr.
Oh my.
And her area of special interest is leukemia and hemoglobinopathies.
Okay.
And not taking much time. I must
so Ramesh Bhai, just one minute I interrupt you. I must tell, because I'm sure there are some youngsters who are and some practicing young pediatricians. Viva was actually a pediatrician. She started practice, was married, having children for almost 5-10 years or maybe more. And then she once decided, no, I must do some specialty. She met me and I said, come over to Wadia. She came to Wadia, keeping away from the family, did the fellowship for 2 years, and now became a qualified hemato-oncologist, went back to Bharatiya Vidyapeeth and established a department today, and they have now students. So, you know, a teacher should feel very proud and happy when the student becomes more powerful than the teacher. And I think Viva is a classical example.
No, sir, not at all. Never, sir. Not in this
is something
lifetime,
very inspiring to all of us.
No, it's very inspiring. In fact, that's very inspiring.
But it is, I would say that all the gratitude goes to Dr. Nitin Shah and Dr. Bharat Agarwal, who were so welcoming. Yes, they were so welcoming.
Thank you so much,
so inclusive.
for being on board.
Yeah. Let's start the deliberation for today.
Nitin Bhai will open the inning.
Yes.
Nitin Bhai, you are very fond of examining impact CBC by yourself. So most of us, we subject basic investigation like CBC. In fact, many times patients come with the hemogram report.
Correct.
So when you send for CBC, what all things you look at and how do you interpret CBC?
Correct. So I think I want to, of course, you see the entire report. So generally today you should ask for a CBC from a reputed lab, which has a automated counter. And then I think I demand at least in hematology cases. Your day-to-day cases, it may not much matter, but hematology cases, yes. Second thing, when you have an automated counter report, you look at the RBC series, which includes the hemoglobin, the hematocrit, and all the RBC indices, namely MCV, MCH, MCHC. And you also have an RDW, the red cell distribution width, as a very interesting and very important index, which tells you about the red cell size distribution. Then you look at the WBC count, but not only get satisfied with WBC count alone, but try to calculate the absolute neutrophil count and the absolute lymphocyte count. And both have their own connotation. Like your total count is 6,000 with 10% neutrophil. That is disastrous. 600 ANC means unless proven otherwise, a bone marrow is not working. Maybe leukemia, maybe HLH, maybe something else. As against you have a WBC of 3,500 with 60% polymorph. I'm not worried about bone marrow not working. This may be a viral infection. So when you look at only WBC count in a normal range and you feel okay, everything is okay, no, that should not happen. Let me say the other way. You have a newborn child whose CBC is showing 8,000 WBC, 78% poly and 10% lympho. Now that's a disaster because his ALC, the absolute lymphocyte count, is just around 800 or less than that. That anything below 4,500 is not normal for a newborn for lymphocyte count. That means this child is probably SCID, the severe combined immunodeficiency, unless proven otherwise. So see how you can get fooled by just looking at WBC and not trying to calculate ANC and ALC. So we make it a point to calculate ANC and ALC. So that, and then of course you corroborate that with the peripheral smear and you see that there are no blasts and things like that. And for the platelet, you see the platelet count. You see the platelet distribution width, like how your RDW, you have PDW. So if your platelet distribution width is high, it tells you that the platelets there are large and small platelets. And there is something very important and index, that is IPF, the immature platelet fraction. Now, many counters today, you give them, they give you IPF. If IPF is high, it tells you it's a regenerative marrow. Whereas IPF is low, it tells you a regenerative marrow. Marrow is not responding to the low platelet. Then you put all these three cell lines, RBC series, WBC series, platelet series, and make in your mind what is happening in the bone marrow. Is the problem in the bone marrow or is the problem in the periphery, which is leading to the abnormal count? So I think that is the way I would interpret it. And last but not the least, if I've given only one test to do in my life, I will do a peripheral smear, because that gives you even more value to my my patient whom I am baffled with, rather than these fancy investigations.
Yes, sir. We'll come to peer later on. Now, ma'am, how does retic count help, and what is corrected retic count? Because many of us have not heard about corrected retic count.
So, good evening, everybody. So, retics are basically recently released cells in the peripheral blood. So they are the immediate precursors of your mature RBCs. They circulate in the peripheral blood for about 24 hours in a normal person, and then they mature into RBCs. So basically, retic count is telling us whether the marrow is working. In a case of anemia, where the red cells are being broken down faster than usual, the bone marrow responds by throwing out more red. You have an increased retic count, it is telling you that the RBCs are getting destroyed, but the marrow is good and it is responding to the destruction of these RBCs. Now, when there is a severe anemia and your hematocrit is low, so just the increased retic count may not be informative. So in that case, you have to use a corrected retic count. So corrected retic count is calculated by the observed retic count into patient's hematocrit divided by the normal hematocrit. So that is correction for the anemia, basically. Retic count rises in many hemolytic anemias. To give a simple example is hereditary spherocytosis. So that is a main thing, but we must remember that retics may rise in different conditions like bleeding also. So that is the importance of retic count. It is the normal retic count in a person is anything around 2.5 or less than that percentage. And it is on a normal peripheral smear, you can see as polychromasia. But to do a proper retic count, you have to do a supravital staining by brilliant crystal blue. That's how it is identified.
Okay. So Ramesh, if I have to intervene, retic count is a window to the bone marrow.
Yes.
Normal or high retic count, marrow is normal. Low retic count, marrow is not responding to the anemia which is there. So that is, and as very rightly said, it looks like a macrocyte. So your MCV is high. And you have polychromasia, tells you that this is a retic on peripheral smear, but otherwise you need supravital staining to know the reticulocyte count. So if a CBC without retic is like a barber without knife
Okay, great.
in an anemic patient.
Right. Nitin bhai, we
Right.
used to examine peripheral
Absolutely.
smear during our residency days,
Right.
but I think you have continued till now. So how does it help? Because I heard that you are very fond of examining
Yeah.
peripheral smear by yourself only. How does it help
So
you?
in my personal practice, I have no laboratory in my clinic except I have only one microscope and staining material. And that is essentially to stain peripheral smears and seeing them, and to stain my own bone marrow and seeing them. Besides that, I don't do any further test. I send it to the pathologist because that's their work. Now, a peripheral smear is a very informative, bedside, cheap, on the spot you can do. Like I'll just give an example. I had a patient coming to Hinduja at night from somewhere from Dubai. Child was anemic. Child was very sick looking. Child had indirect hyperbilirubinemia, and there was some splenomegaly. Now confusion about what is what. I took a smear, came back home, stained and saw, and I saw micro spherocytes, and I saw some broken cells and low platelet. I knew it is HUS. So I said, okay, do creatinine. It was 2.4, and the diagnosis made only on peripheral smear. So the peripheral smear helps you first to document what the counter is showing. So you don't only rely on machine, you actually confirm whether it is macrocyte, microcyte, or normocytic, whether it is hypochromic, normochromic. That's for the RBC. In WBC, you see atypical lymphocyte, you see blast, you see a lot of monocytes. All that will help you from the WBC point of view. In RBC, you may also see abnormal cells like sickle cells, spherocytes, broken cells, target cells, etc. That helps you to cleanse the diagnosis. On a platelet, like suppose you are a child with isolated epistaxis, the platelet of say 30,000. All right, now I do a smear and I see large platelets. I know it's ITP. I do an IPF. IPF is high, 15%. I need not do a bone marrow. I can make the diagnosis of ITP based on the peripheral smear. So the peripheral smear is the most, it actually sometimes diagnostic of a condition. And I'll tell you,
Especially in, yeah,
we have
hemolytic
from
anemia.
Wadia
Yes.
reported even hemophagocytes on peripheral smear. During the outbreak in 80s, when Dr. Zinat Karimbo was working in Wadia, she and subsequently he also saw hemophagocytes on peripheral smear. So peripheral smear is very important.
Right. Now, Vibha ma'am, Nitin bhai talked about IPF, immature platelet fraction. So how does it help?
As sir has already said, basically IPF is to the platelet count exactly what retic is to the RBCs.
Correct.
So in these newer counters, the more advanced counters, these are the newer indices which are available. And what it tells you is how much is the immature the immature platelet fraction. So basically, when your platelet count is down, when it is low, and you wonder what is happening to the patient, so is it that the platelets are getting destroyed in the periphery, or is it they are not being made? Now, these are two very different conditions, and the conditions where they are not being made, a sick marrow is really, really very serious kind of diagnosis. Whereas if they are being destroyed peripherally, that is also not a good diagnosis. But yes, it's a better one. So if you're with a low platelet count, if your IPF is high, you know that the platelets are being destroyed in the periphery. For example, a condition like ITP. For example, a condition like dengue fever. So in dengue fever, the platelet count is low, but you do IPF, it is high. You can reassure the parents that tomorrow, day after, the platelet count is going to rise, and you can avoid a platelet transfusion, which should be anyways avoided. But that is one way to assure the parents.
Absolutely.
So it's a
I'll
very
just give
useful
Yes, Nitin bhai.
action.
I'll just give another example. I had a child from Gujarat. He was referred for fever, then off and on, 2-3 time admission with Pancytopenia. Marrow was done before normal. Marrow was done at our place normal. He had on the CBC when he came low plated around 50-60,000, not bleeding. And he had anemia of around 8 grams and WBC, which was low and low ANC. So now what is this? He got a lymph node in the chest and in the abdomen, 6 by 6 centimeter. Now it's a lymphoma. We should biopsy that. I said, you first do IPF and Coombs test. Coombs test came positive. IPF was 15%. Now I know there are double antibodies in this child. He can't have lymphoma generally. So it has to be some immune disorder. And I mean, Vibha will understand what I'm trying to say. That it was an autoimmune lymphoproliferative syndrome, or ALPS. Diagnosis made by that IPF and Coombs test. And of course, we did the biopsy of the lymph node because we have to rule out lymphoma. ALPS can be also associated with lymphoma. But biopsy came normal, and all you needed was steroid, and the child is completely okay following for 5 or 6 years. So these things to put together, not single test should be interpreted in isolation.
Absolutely.
Put together gives you tremendous information as to what your patient is likely to have.
So we should ask for IPF in
Yeah,
short.
absolutely. I mean, I will give another example. There was
Yes.
another child who had some surgery required for some DVT, something, and the platelets were 70,000. The surgeon said, referencing that, why the platelets are low. I said, you have done IPF? No. IPF was high. I said, no, this child is adolescent girl, has got thromboembolism and a platelet weight. So this looks like SLE. We did an ANA is positive. And see, diagnosis is made only based on one simple investigation. So these investigations are very, very important in a hematological oncological patient.
Very, very interesting. Now, Nitin bhai, most of the time during 1 or 2 or 3 days history of fever, and people subject it for CBC. Sometimes even parents also come with hemogram report.
Correct.
So can it help me narrow down to differential diagnosis only CBC?
Yeah. So let's take, say, bacterial versus viral. That's the commonest, give antibiotic, not give antibiotic. So while it is not a sacrosanct, but generally in bacterial, the counts are high, the neutrophil count is high. There might be toxic granules seen on the peripheral smear, which only if you have seen the smear, then you can know. Because I'm telling you, believe me, the pathologists have no time to even sign the reports. Forget about seeing a smear. Seeing a smear takes half an hour. So they don't have time to spend. So toxic granules like that. Then you have platelet count, which is low, borderline low, and the hemoglobin is normal. You are surely, I mean, the platelet count is normal and the hemoglobin is maybe borderline low, 1 gram less than what before. It's an acute infection, most likely bacterial. Then you search for a focus. Where vis-a-vis you have a WBC count which is borderline low, you have a normal ANC, and you have borderline low platelet and a low hemoglobin, borderline again, and a smear which someone has seen like me, one of us, me or Vibha, and show some atypical lymphocyte. It's viral infection. So you can wait. There's no need to hurry with a bone marrow. So bacterial versus viral, you can sort of make a judgment. And there are, of course, individual diseases which will have a pattern of CBC.
But one thing that I think clinicians should not rush to do in hemogram on the very first day. Some viral infections can have a neutrophilia, a relative neutrophilia, not absolute, on the very first day. Yeah. So I suppose, again, history, clinical judgment will always take precedence.
Yeah. And we are all aware about the NLR, the neutrophil lymphocyte ratio during COVID time. If it was high, it was disastrous in an adult. Yeah. Of course, pediatric, it never had too much of attention. But so what Vibha is saying, we were right, like in COVID, you had more lymphopenia than and a neutrophilia.
Yes. Right. Now, what we used to see into differential count, basically polymorphosis and lymphocytosis. Nowadays, I mean, people have started looking at eosinophils, even monocytes. So, ma'am, what is the significance of high eosinophils or monocytes in CBC?
So basically your differential WBC count will have, the report will have neutrophil, lymphocytes, monocytes, eosinophils, and basophils. So monocytes, basically normal monocytes are never more than 10% of the total WBC count, or absolute never more than 1,000. So if you have monocytosis, that is increase in monocytes, you can think of two conditions. The commonest is the secondary, where you will have so many infections, and the uncommon, which sir or we will deal with, will be a primary cause of monocytosis. So the secondary monocytes are usually due to infections. There can sometimes be acute reactions, for example, corticosteroids or exercise or acute infections where you may get monocytosis, but that will go back. It will become normal. But if you're still in monocytosis, then it can be some infections, chronic infections like TB, leptospiral, listeriosis, and sarcoidosis, brucellosis, typhoid fever. So these kinds of infections, you may see a monocytosis. Yeah. So malaria, yes, malaria. The malaria, TB, brucella, typhoid, is that what we see? And just for knowledge sake, the primary causes of monocytosis are clonal. So conditions that we see in children is juvenile myelomonocytic leukemias, or adults will have, sometimes even adolescents will have something known as CML, where absolute monocytosis is a criteria to suspect and diagnose these conditions. So those are myeloproliferative neoplasms. And there will be, other than classical clinical presentations of a huge splenomegaly, you will have absolute monocytosis over there. And coming on to, yes, sir.
Yeah, so just to, before she goes to eosinophilia, that a recovering marrow will always show monocytosis, like
Yes,
all leukemic
yes,
children. When they have
yes.
given
After
chemotherapy, now the
chemotherapy.
counts have gone down. Moment you have 30%, 40% monocytes, next 2 days the absolute neutrophil count also will
Count is
rise
going
because the
to be
marrow is now responding.
absolutely.
Okay, you can go
Absolutely.
ahead, Viva, for the eosinophilia.
For
So,
eosinophilia.
as I said, then eosinophil is the another count which we see on the CBC report. The normal eosinophil count will not be more than maybe 5 to 6%, or the absolute eosinophil count will be somewhere less than 500. So, eosinophilia you can divide into three. You can have mild eosinophilia, moderate, and severe. Mild is from zero point 0.5 to 1.5, that is 500 to 1500. Moderate is from 1500 to 5000, and anything more than absolute eosinophil count more than 5000 is a absolute eosinophilia. So again, as I said, it can be divided into primary and secondary causes. And secondary causes, more than 95% of the times, eosinophilia will have secondary causes. And the commonest reasons in our pediatric practices is a worm infestation, parasitic infestations, allergic conditions. Now more, it's taking precedence. Our children no longer get worms.
Right.
But yes, but allergic conditions, so allergic rhinitis, asthma, and so many autoimmune disorders will have eosinophilia. And coming on to primary eosinophilic syndrome, they are again clonal, or there are then a huge lot of myeloproliferative neoplasms will have absolute eosinophilia. There are some primary immune deficiency syndromes like hypereosinophilic syndromes, which will have absolute eosinophilia. And they can have counts as high as 50,000 of absolute eosinophil counts. And due to this high eosinophils, they also get some organ damage. So those are totally different kind of things. What a commonly pediatrician would be see is a eosinophilia due to all these secondary conditions.
Yes, thank you,
Correct.
ma'am. Now, Nitin bhai,
Yes,
in a season of enteric fever, if
correct,
I get a patient, then from CBC only, can I
correct.
guess that it could be enteric fever from CBC only?
Correct. So that's not that easy, or it's very specific. But if you have a enteric fever, so first of all, if a septicemic enteric in a small child, there can be neutrophilia and a high count. But generally, older children, they come with little borderline low count. They have little low platelet and they have zero eosinophil. So if you have zero eosinophil on a smear and your CRP is very high and you are on 7 day of high fever, which is going up and up every day, for sure that's enteric fever. You do a blood culture and you will be rewarded.
Oh, that's great.
And there
And
may be
ma'am, same, yeah,
monocytosis again.
Yeah.
There might be a monocytosis.
and Viva ma'am, same about another common condition, dengue. Can we anticipate it from CBC only?
Yes, sir. So dengue fever, after a classical clinical situations, if you have a a mildly higher hemoglobin, higher hematocrit, leukopenia, low WBC count, neutropenia again, mild lymphocytosis, monocytosis, low platelet counts, and this is a classical case of a dengue fever.
Right.
And then there is the importance of doing a serial CBC count. So when you know that your child is improving, all these things will start reversing. And here again, as I said, and Sir has said before, the IPF will come. So IPF, which was high, starts falling down. You know that your platelet count is going to increase. So that is a time when your child is now turning around and is now likely to recover. Whereas if your hematocrit keeps increasing, hemoglobin keeps increasing, there is leukopenia decreases, then you know that your child is still not turned the corner.
So
I
dengue
just
is a
add,
very
I
interesting
just
case.
add two
Yeah,
more
yeah,
things
Nitin.
on whenever you're on dengue. The number one, that if you have a persistently high IPF and a low
Hmm.
platelet, long many days after the child is completely okay and discharged, that's a secondary ITP following dengue. So that should be treated like ITP. And second, if your platelets are very low and the IPF suddenly gone down and your other counts are going down, the child's fever returns without reason, then you think of HLA, do a ferritin, that is more than 5,000, 10,000. You are dealing with a secondary HLH following dengue, and maybe a short course steroid is all that you need to recover such children.
Oh,
Yes,
great.
absolutely.
Now, Nitin bhai, similarly, another common condition, malaria. From
Correct.
CBC only, one can judge
Right.
possible malaria.
Correct. So malaria typically leads to hemolysis and a bone marrow suppression. So when it leads to hemolysis, there will be low hemoglobin. Maybe there'll be red count will be higher. Okay. The WBC may be low, especially in falciparum malaria because of the bone marrow failure, and the platelets will be low. So you have low hemoglobin, low count, low platelet, more malaria. You have high hemoglobin, low count, low platelet, more like dengue. So that's the way differentiates. And sometimes if you have very high parasitic load, then on a CBC on a counter, it actually shows you a flag that there is likely to be a malarial parasite. So of course, it's a very technical, we don't go by that, but you will obviously look at a smear. And again,
Yes.
when you look at the smear thin and the thick smear, many times you will pick up malarial parasite. But again, who has the time to see smear for 20-25 minutes? Nowadays, you have malaria antigen test. I'm sure they are more easy and they are very specific and sensitive. So if you have no time or no good person to look at the smear, just send the malaria antigen test.
Okay.
So,
So
but if
that's
you have a
about
very young and very enthusiastic hematologist and who will look at WBC scattergrams, there are many
Yes,
patterns of a WBC scattergram which are typical
correct,
of malaria. So
correct.
there's no point in
Yeah.
elaborating that.
It will flag
But
out on
there
the
are
counter report. Yeah.
so
five,
in
six
the
different
era
patterns
of
of
Met, still
hemolytic.
CBC counts as far
Yes.
as malaria is concerned, right? Now,
Yes.
there are some
Today, Ramesh
yeah,
bhai, people
yeah.
come to us with a genomic sequencing, whole genome sequencing, and then we have to go back to peripheral smear to diagnose. So, we are going in a
Sir,
completely reverse era.
it happened with me, sir. The patient came with a whole exome sequencing diagnosing thal trait. Then from the
Absolutely.
CBC, I said, "Arey CBC में ही दिख रहा था thal
My
trait."
God, that's terrible. That's
Yes,
terrible.
sir, that was
Terrible.
terrible, sir.
So
Yes.
basic always remains basic. Now, Vibha, ma'am,
Yes.
there are some
Yes, sir.
enthusiastic pathologists who write that there are atypical lymphocytes. So, I mean, all
Yes.
pediatricians are confused. I mean, what does it mean?
So when atypical lymphocytes, so let's talk about the real atypical lymphocyte and a little bit atypical lymphocytes, which the pathologist, not an expert, but a pathologist who is scared to say what it is. So let's talk about that later. So the classical atypical lymphocyte is basically an activated lymphocyte, the lymphocyte which has been a normal lymphocyte which has been challenged by some antigen and which is activated. So what does the activated lymphocyte looks like? It is little bigger, the nucleus is more open, the chromatin is open, there is nucleoli in there, the cytoplasm is bigger, it's more cytoplasm, and the main
Abundant.
thing is that it indents the RBC. So it's a very it's indent, so it has amoeboid kind of all different kinds of shapes, and these kinds of activated RBCs you will see many viral infections, but the classical ones have been described in EBV, CMV infections, your infectious mononucleases. Now
And
what
hepatitis A.
Okay, sir, hepatitis A.
And
And
sometimes
what,
phenytoin. Phenytoin.
sir, and we are worried about is that many times the CBC report, which says atypical lymphocytes, and we really worry because they are probably which the pathologist is really scared of writing, and then that's what brings our antenna up.
Correct. So when you
So
have a
that is where
CBC,
again an expert peripheral smear.
yeah.
Yes,
When
sir.
you have a CBC which shows 90% lymphocytes and the pathologist says there are abnormal lymphocytes, or
Sites or
then
atypical
you be
lymphocytes.
for
Yes,
sure they are all actually
they are
90%
actually
blasts.
blasts.
Yeah.
So actually, there is a proper difference between the
Yeah.
blasts and atypical
Yeah.
lymphocytes.
In
But
fact, to tell you very frankly, I have some pathologist friends around. They will send their smear to me saying that अरे इसमें देखना blast है क्या? I nowadays have
no.
started saying that okay, I will see the blast or no, but you have to refer the patient to me then.
But I don't blame them because writing blasts, and nowadays parents will immediately Google it and then you've had
Yeah.
it. So I
I
suppose they want
remember
to avoid
Viva.
the situations.
I remember once there was a pediatrician who had referred a patient like that. This patient's count is 90,000 and he's showing blasts. Okay, and he was actually looking like a hemolytic anemia, and there were blasts, but they were normoblasts. They were not
Okay.
lymphoblasts. So sometimes
Okay.
those mistakes also can happen.
Oh, yes. So,
Now, sir, Dr. Jayant Joshi, I think he had written on chat that
Uh-huh.
based on RBC indices, can we differentiate between iron deficiency anemia and thalassemia trait?
Absolutely, you can not only the indices but the entire RBC. So suppose you have a 7-year-old child. Now he has no business to iron deficiency generally. Okay, he's from a high risk community. Say he's a Sikh, Punjabi, Gujarati, Bania, Lohana. Okay, and his hemoglobin is 10.5, which is not that low, but the MCV is 55. So a very disproportionately low MCV for the amount of hemoglobin tells you that this is not iron deficiency. And you look at the RDW, if you have an MCV of 55, the RDW will be very high in an iron deficiency anemia, whereas this fellow RDW will be 13, 13.5, 12.5. Then you look at the RBC count, 6 million, 6.5 million. So you have a borderline low hemoglobin and disproportionately low MCV, a normal RDW, and a high RBC count, unless otherwise thalassemia minor. You look at the smear, it will show you RBCs which are microcytic, but they are all of uniform size. That means there is no anisocytosis. And if you are smart enough and time again to spend on peripheral smear, you will see somewhere some hemolysis like polychromasia or a reticon which is a little high. This tells you, in fact, I mean, the obstetrician should actually understand this more, because nowadays, of course, in cities, they ask for electrophoresis for every prospective pregnancy, mother and father both. But in periphery, where it may not be done, if the obstetrician is smart to, as I said, pick up this from the CBC, he can actually pick up a thalassemia minor and prevent the birth of a thalassemia major child.
Yes, yes.
And last but not the least, Ramesh bhai, there is such a patient, you put them on oral iron and they won't respond because they are not iron deficiency. That tells you again that you are dealing with thalassemia minor. And all you need to do is electrophoresis, HbA2 is high, and you cleanse the diagnosis.
So Nitin bhai, here, when you are suspecting iron deficiency anemia, does iron studies help?
So absolutely not. I mean, I generally don't. If the patient is in the age group where iron deficiency is common, that is between the age of say 9 months to 3 years or 5 years, or adolescent girl, or there is history of bleeding, which tells you that probably is losing iron, and he has microcytic hypochromic anemia with high RDW, and an MC which is proportionately the same as the hemoglobin, and RBC count also is low, and I see the smear, it shows you anisocytosis, especially you see ovalo anisocytosis, then that is iron deficiency. You put them on oral iron, you repeat hemoglobin after 1 month and 3 months, hemoglobin should become normal by 3 months, then you have treated iron deficiency. There is no time to waste money on the iron state. But if you're doing iron studies, like suppose you have a 8-year-old suspected iron deficiency, probably you are justified doing. There also don't do serum iron TIBC transferrin saturation in children because it's very diet dependent. Straight do ferritin. If you have no fever, then ferritin is pathognomonic of iron deficiency. If you have fever, then you wait for 1 or 2 weeks after fever subsides and then do ferritin. So low ferritin tells you the iron stores are gone and this is iron deficiency. So I generally don't do iron studies, and I do only ferritin if I have to do iron studies.
So during fever,
if you want to know the response early, you can do a retic response.
Yes, so 7 days retic, but that parents generally don't like. In a teaching institute, we do it. In private settings, I think 1 month, 3 months is a good enough way to diagnose.
Yes, yes.
So Nitin bhai, same way, you can, based on CBC, can you diagnose megaloblastic anemia, or you need to do B12 and folate?
So again, I don't do B12 and folate deficiency. If there's a typical megaloblastic anemia, what is typical? No fever, no organomegaly, no lymphadenopathy, no weight loss much, no limb pains. Because megaloblastic anemia will have pancytopenia. Okay, so you're worried about leukemia always. So these are all sinister signs are absent. Now coming to hemoglobin is low, MCV is high, more than 9500, generally 110, 115. Okay, RDW is high, unlike in aplastic anemia. All right, and you see basophilic stippling, you see cabot-ring, you see polychromasia, and you see our friend, as I call, hypersegmented neutrophil. If you see a single cell with 6 lobes or more than 5% cells with 5 lobes, it is pathognomonic of megaloblastic anemia. All you can do is some biochemical test like LDH, which is high, and it tells you. And other thing, again, don't do B12 folate alone. If you want to do with homocysteine. Because when you have B12 low and folate low and you have high homocysteine, it's a functional disorder that you're discussing. Many, like 10% of the population will have low B12. And other way, 20% of patients with megaloblastic anemia will have normal B12. So either way, it really doesn't help. So if you want to do, you should actually do it with homocysteine and methionine, but both are very expensive. B12 folate themselves are expensive. I generally put them on oral B12 and folate and see the response in the next 1 or 2 months.
Yeah,
if they respond, you have treated megaloblastic anemia in hindsight.
Approach, right? Now, ma'am, is there any condition where you need bone marrow biopsy to diagnose?
So again, as a very classical, as sir has already said, very classical B12 folic acid deficiency in the age group leading to a nutritional kind of situation, there is no need to do a bone marrow now. Maximum, if you want to prove after looking at the peripheral smear, doing LDH, homocysteine, you can do a B12 or a folate level. That comes low and homocysteine comes high. That is definitely, we used to, once upon a time, we used to do a marrow for B12 deficiency. Now we no longer do it. But sometimes if you have further conditions like rare, very rare disorders of B12 folate metabolisms, some congenital transcobalamin, these kinds of disorders, you may need to do a bone marrow to prove megaloblastic anemia, but very rarely. I don't remember last when I did a marrow for a B12 deficiency.
So the one exception where maybe you are justified doing upfront B12 folate and maybe in a marrow is an infantile tremor syndrome. That can really be confused with a lot of other condition, and that's an emergency. So you do a B12 folate low, you do mother CBC. That shows you there is some macrocytic and anemic picture telling you the mother also is B12 deficient. And then you treat these children with injectable B12. Normally, we don't give injectable B12 in older children. You give them oral because there's no malabsorption. It will be absorbed. It's not pernicious anemia, right? That you need injectable lifelong.
Absolutely.
But in infantile tremor syndrome, you will give injectable because you need faster recovery, because the damage in an infantile tremor syndrome can remain permanent to some extent if you're not treated in time. So that's the only indication where there is emergency for to diagnose as well as to treat.
So
and sometimes if your clinical situation is not fitting it with the CBC, CBC is like a B12 deficiency pakka, but clinical situation, big child eating non-veg almost alternate day, then you should do a marrow, because sometimes some leukemias may come as a increase in MCV, Pancytopenia. So if you're not sure, please go ahead, refer and do a marrow. Be sure that you're treating only B12.
And remember, your LDH is high both in megaloblastic anemia as well as in leukemia. So you can't differentiate based only on that. But of course, uric acid, yes, will be high in leukemia, will not be that high in megaloblastic anemia.
Yes, but again, AML, that will not be high.
Yeah,
so there are confusing situations.
Very interesting. Now, Nitin bhai, from CBC, PS and Retic, can one know that it is a hemolytic anemia?
Yeah, so you have a low hemoglobin, and you will have probably a normocytic or a macrocytic, depending upon the reticulocytosis. A normochromic, that means the iron deficiency or B12 fold deficiency is not there. And you will have a high retic, tells you that the marrow is responding to the cause of anemia. Next, you look at the smear. Smear shows the evidence of hemolysis. What is the evidence of hemolysis? So you will have a macrocytic, you will have anisocytosis, you will have polychromasia, and you may have a capillary ring, you may have other features. And then specific to the hemolytic anemia, like if it's spherocytosis, you will see spherocytes, microspherocytes. If it's sickle cell anemia, you'll see sickle cells. If it is microangiopathy, like in a hemolytic uremic syndrome, you'll see low platelet and broken cells. If it is thalassemia, you will see target cells, and so on and so forth. So you will have characteristic picture. So overall, a common picture to all hemolytic anemia, and then something specific. And many times we make diagnosis based on peripheral smear alone.
Absolutely.
Vibha ma'am, do you need any extra investigations to stamp hemolytic anemia apart from what Nitin bhai said?
So, like diagnosing hemolytic anemia is like climbing a step ladder. So you have to go by first history examination. A peripheral smear is as good as a clinical examination in case of hemolytic anemia. And from there on, you do tests. Because if you start doing tests just like that, it's like finding a needle in the haystack. So as sir has said, after you've reached there, you found a spherocyte in the peripheral smear. Then you can go on for osmotic fragility, again, which we are not relying. It's a very laborious test. It can be false. So nowadays, what we are doing for hereditary spherocytosis is your flow cytometry for red cell membrane and by EMA binding. So similarly, if you're suspecting autoimmune hemolytic anemia, because if you see large RBC aggregates, you see hemoglobin urea, suddenly the hemoglobin has fallen down, again a reticulocyte count, and then you do a DCT and immediately you have a diagnosis of autoimmune hemolytic anemia. So similarly, if you found a sickle cell and the patient is from that area, he has bone pains, you do a sickling test and within an hour you have a diagnosis, which can be confirmed later on a HPLC examination. So on and so forth, you have to narrow down your diagnosis and do specialized tests accordingly.
Correct. One more thing I will just tell you, Ramesh bhai, for pediatrician, that when you look at the CBC in a hemolytic anemia, look at the MCHC, the mean corpuscular hemoglobin concentration. Now people don't see that at all. They just
one
see
single use of MCHC.
If MCHC is say 45, 47, you for sure know this is spherocytosis. And if your MCHC is 70, 80, for sure you know this is acute immune hemolytic anemia because of cold antibodies, because there are masses of RBC which are picked up as single RBC, giving you a haywire report on a counter. So, simple things on CBC, if you pay attention, you will come to know.
Great. Nitin bhai, we get so many times reports of HB electrophoresis.
Correct.
And I mean, it is so confusing and to most of us. So just elaborate.
Correct. So I think, first of all, if you are suspecting thalassemia, never do electrophoresis in the first 6 months. Do it after 6 months, because fetal hemoglobin transition from fetal to adult life happens just before the delivery, say 2-3 months before delivery, where it is almost 90% fetal hemoglobin to 0 or 1 or 2% by 6 months. Okay. So if you do before 6 months, it will confuse you. If you have done, then there are nomograms available for different age after birth at which what can be the maximum fetal hemoglobin, but that's a very crude way. Ideally is to wait for 6 months. Sickling you can diagnose at birth by doing electrophoresis, because sickle cell is present in birth. So you do, and you see hemoglobin S is high, that tells you it's sickling. So these are the important. Now remember, HbA2 high alone tells you it is thalassemia minor. But in a thalassemia minor, HbA2 is high up to 7, 8, 9%. Moment you see 15 and 16% HbA2, it is not HbA2, it is hemoglobin E. And especially that fellow is a Bengali or an Orissa or a East Indian origin, then that's hemoglobin E. That is the hemoglobin E and not hemoglobin A2. And same way, hemoglobin D, which is of course asymptomatic, moves with hemoglobin S. So if you have, whenever you have an HbS band, do you do sickling test? If it is negative, it tells you it is hemoglobin D. And if sickling is positive, it tells you hemoglobin S. And last but not the least, you have to do the parent study. Don't rely only on the child study. So suppose you have thalassemia major. So 8-month child, hemoglobin F is 90%. This is surely thalassemia. You do both the parents are obligate carriers, the HbA2 will be high. Same way, suppose you have a patient with hemoglobin S, which is 60%. Now you don't know whether it is sickle cell anemia or is a double heterozygote like thalassemia with sickle. So you do parent study. One of the parent is thalassemia minor, other is sickle trait. You know this is HbS thalassemia sickle trait together. Whereas both the parents are sickle trait, then this is sickle cell anemia. And last but not the least, to confuse between sickle trait versus sickle disease, whether it is heterozygous or homozygous, is cutoff of 50%. HbS below 50% is more likely to be trait. HbS is more than 50% is more likely to be a disease. More the hemoglobin S, more likely to be a homozygous sickle cell. And if you have a high HbF with high HbS, is likely to be a thalassemia with sickle as a double heterozygote. So that's how you will actually differentiate. But of course, there are some rare cases which is beyond discussion here, is for specialists, where you will have child is thalassemia major. Now the mother is trait and the father is not trait. Now he will accuse her that this is not my child. It has happened. And then we have to do explain him that you are a silent carrier. Your hemoglobin A2 is normal. So we do directly a beta gene sequencing, and he is found to have a mutation, and that settles down the entire family. So there'll be some nuances where these things can happen.
Yeah, and there's something new.
Now, I think, sir, I want to just, because this is a platform of pediatricians, one thing I just want message that I want to give is that if you have a child with anemia, don't transfuse before you diagnose what it is.
Yes.
If you are transfusing, you must know what you are transfusing for. Because
so no
if it
transfusion,
is,
no steroids.
Yes. Because if you transfuse and your HbA1c is confused, then we are also confused. Everybody is confused.
So remember, Ramesh bhai, what Vibha is saying in a hemolytic process, but even a leukemic, if you transfuse haphazardly, it's enough to lead to temporary remission. Absolutely. And the patient will come back with relapse after 3 months. So steroids and transfusion, no, unless you've done a marrow in a suspected child with leukemia. And thalassemia, suppose someone comes transfused to me, what I have to do is now do beta gene sequencing for
now
the child.
It's become easier.
He has to have 2 mutations, one from the father and one from the mother. So we do all the 3 direct beta gene sequencing, and we come to know what mutation is it.
Absolutely. So that is now become easy, but initially it used to be very costly and not available. Yes.
Now, Vibha ma'am, if HB electrolysis comes normal, then what other tests are done to know the etiology of hemolysis, osmotic fragility, or RBC enzyme studies?
That she alluded to.
Sir, I couldn't hear
suppose HB electrophoresis is normal.
Yes.
Right? Then what other tests are done? Like osmotic fragility
in
or
the case
RBC's
of,
enzyme
yes,
studies?
Sir. So as we said, if it is a hereditary spherocytosis, then nowadays we go in for the RBC membrane studies. It is done by flow cytometry. So where you get the membrane units, and that is, if that is less than the normal range, then you can diagnose a hereditary spherocytosis. And because osmotic fragility is very laborious and many times it is incorrect. So going on to next would be an enzyme deficiency. So G6PD is the commonest enzyme deficiency. It is X-linked, and you will have a very classical smear there also. So you will have those classical bite cells, and you will have a lot of polychromasia, high MCV. Suspecting that, you do a G6PD and you will have the diagnosis. If you don't get G6PD and you still suspect an enzyme deficiency, then you have the rarer enzyme. For example, pyruvate kinase.
Vibha, we are not able to listen to you. Your bandwidth has gone down.
Then there also you need to do specialized flow cytometry study to diagnose that PNH. And then so which one antibody IgG report, which is and complement
little connection.
The other things that other hemolytic anemias commonly we see in practice.
Okay, so I think Vibha, we lost you in between, so we couldn't hear you properly. But what I understand what you are trying to tell you is that if you have a patient with normal electrophoresis and a normal flow for membranopathy, then you are left with enzymopathy and rarer membranopathy. So enzymopathies you can do by each enzyme, and there are tests available in many laboratories. And if nothing comes positive, then you do a genetic test to find out what the cause of that hemolysis is. One thing I want to caution pediatrician is that when you suspect G6PD, generally it's an acute. You don't see chronic hemolytic anemia in our country like you see in USA. So they are acute. And when you acute hemolysis, there is so much of reticulocytosis that the reticulocytes are very rich in G6PD. So if you do a G6PD immediately, it will come normal. And you will say, oh no, this is not G6PD. Never do that. You repeat after 3 months. And then after 3 months, the G6PD will come low, then you know you have diagnosed. This is also true for neonatal jaundice. So suppose you have a child who was sent home on day 3, day 5 come with 35 milligram bilirubin and anemia. You know it is hemolysis. You do a G6PD is normal. Never assure the patient that this is not G6PD. You do exchange, you do everything, and you ask them to follow up after 3 months again with a repeat G6PD.
And the quantitative test is better than the qualitative. So we should go for the quantitative test of G6PD.
So that is very interesting, Nitin bhai. Now, Nitin bhai, if we have got a patient with bleeding and the platelet count is low, so how does one know that it is ITP or something else?
So generally, ITP is a well child, no hepatosplenomegaly, no lymphadenopathy, no fever, no weight loss. Isolated bleeding, nothing else. Vis-a-vis aplastic anemia, leukemia, which is the close differential, you will have sick child, you will have a long history, weight loss, hepatosplenomegaly, lymphadenopathy, leukemia, but no organomegaly in an aplastic anemia. And look at some features of congenital aplastic anemia like Fanconi's, etc. And then you do the CBC. You see isolated thrombocytopenia is more likely to be ITP. Then you do IPF. IPF is high. It tells you it's regenerative marrow, so the marrow is normal. And you look at the smear, shows no blast and shows a mega platelet, then tells you this is ITP. In such case, you may not do bone marrow if you're not going to give steroids. But if you're going to give steroids, then I would insist that you do bone marrow, because at least once in 2 years, we have seen one leukemia completely confusing you as ITP. And if you're not done the marrow and given steroids, then he will come back as a relapse after 3 months.
Yes.
So Vibha ma'am, what Nitin bhai said about high IPF. So suppose if there is high IPF, then can you avoid bone marrow in this patient?
In the case of ITP. So in the case of ITP, as sir said, it's not that every ITP you have to treat. And ITP counseling parents is very important, more than treatment, because you have to tell them that you are going to treat the child and not the reports. So if the child is not bleeding, you don't have to treat, and you can just wait, follow up the child. You can explain to the parents that you come back if there is any major mucosal bleeding. Skin bleeds are not so important. Or you can decide to treat if the child's platelet count is 10 and he's a very active child, playing all the time, falling down, then you may decide to treat. So if you're treating with steroids, then you need to do a bone marrow. Then you need to do a marrow, sir, as said. And then there are many logistical situations in ITP, sir. I'm sure you are also aware. If the parents are staying far away, if you feel that they are not understanding the situation between a leukemia, what are you doing? and if you feel that their follow-up may be doubtful, then it is better to do a marrow and once for all. And other thing is, sir, what in my practice I realize is that children with ITP, they keep coming again and again. They come maybe for 6 months, maybe for a year. Most of them go into remission, but at least few visits they come. And every time it is not possible to admit them and do bone marrow. So once if you have admitted already, then it is better to do the marrow. So next time they come in your OPD, you can directly start oral steroids just for 3 days, 4 days, give a high dose for short course, and you just manage that episode instead of giving long courses.
The other thing, Ramesh bhai, is that when
Yes.
you suppose you have decided not to treat this ITP, it's
Hmm.
not that you just sit at home. It's not non-frantic watchful waiting, is watchful waiting. Which means he'll come back after 1 week for another smear. If the blast was not seen last time, maybe you will see this time after 2 weeks, 3 weeks, 1 month. So you keep on following them up. If there
Yes.
anything goes abnormal, suddenly liver spleen comes up, etc., certainly you will do a marrow at that time at least.
And at
And
this
any
point
chronic
of time,
ITP.
yes,
Yeah,
sir.
beyond 6 months, 1 year, it may be worth doing marrow once just to rule out that there are no other causes. And very young ITP, a 4-month child ITP, it may be a megakaryocytic thrombocytic uremia. In
Yes.
such child, better do a bone marrow and show that there are megakaryocytes which are normal or increased.
And in this case, a CBC becomes very important. I have seen
Yes.
that mild neutropenia, mild anemia is missed, and that's how the child is taken up as ITP and treated. Leukemia should be suspected in such cases.
Correct.
Yeah.
Correct. Now, Nitin bhai, let us focus on bicytopenia or
Okay.
pancytopenia.
Okay.
Which cases need bone marrow? Because this is a very common scenario in clinical practice.
So a bicytopenia which is acute and your smear is seen by a hematologist or a smart laboratory person and there are no blasts, you can wait. Especially if you have a reason to have biocytopenia like an infection, Enteric, malaria, as we discussed all that, and you follow them up overall term, like 3 days, one more CBC, another 1 week. If they are showing increasing trend, you can leave alone and just keep on following till the child is completely all right. If it's showing decreasing trend of the counts, then you know there is something which is worsening, then you need to do a marrow. A pancytopenia, unless it's megaloblastic anemia or hypersplenism, which is a completely different picture as compared to a sick child with fever, hepatosplenomegaly, etc., is an emergency. You should first see a smear. Many times you will see blast on the smear. So suppose your count is 20,000 and you have 80% blast. There's no need to do marrow. You can do peripheral blood flow cytometry to diagnose which ALL it is. But if you have 4,000 count and 10% blast, then peripheral blood will not be enough. Then you need to do the marrow. So marrow is done for 2 reasons. One is to confirm which leukemia. Second is to get liquid marrow to classify what leukemia is it and for doing cytogenetic study. So this is the way I would approach a bicytopenia or pancytopenia, that on follow-up, especially if the smear is showing some abnormality or the patient is deteriorating or the counts are deteriorating, don't wait, just do the bone marrow.
So weekly follow-up, and if child is deteriorating,
Yes,
early.
follow-up is very important. For example, a child with
sometime every 3
brucella or
days.
malaria will also have low counts. But
Yeah.
idea is to follow up.
Yeah. And suppose you are diagnosed malaria, you give an anti-malaria, he should respond, right? If 1 week, 10 times the count don't come up, that means it was not malaria or something else.
Absolutely.
Now, ma'am, initially, a few minutes back, we had a discussion that before referring to higher center, a pediatrician should not do what? And this is very important. You said
Yes.
that one should not
Yes.
give steroids or one should
Blood
not give blood
transfusion. Yes.
transfusion. Anything
Yes.
else?
The thing is that if you suspect leukemia, that's very good. It's an excellent diagnosis. But then if you are doing a marrow to prove your diagnosis, then be sure that you know exactly what all has to be sent, because we don't just do a morphology. Morphology is the first thing, whereas you diagnose, but then you have to classify the leukemia. You have to do the flow cytometry on that, and not just that, we have to do cytogenetics, we have to do karyotyping, we have to do molecular studies. There are so many things, and one after the other. So basically we have to collect the samples all together. So if you are aware of that, you know what is to be collected. If you are communicating with a hematologist or a referral center, then you can go ahead and do a marrow. But if you are not sure, or if you're sure to send it to a higher center, then don't do a marrow, because all said and done, it is an invasive procedure. It is painful. You need to give sedation for that. So You're all taking a risk. So why put the child to risk twice? And other thing is that if you're collecting the sample, the flow cytometry has to be run within 24 hours. Otherwise, the sample is deteriorating. So if you have logistical issues, it is better to do the marrow where the flow cytometry will be done within 24 hours. So we always worry about these situations.
Yeah.
And as you've already said, blood transfusions or steroids, they can really put the child into remission. But another thing what I want to say here, which you did not ask, is that what the pediatrician should do, because you should stabilize the child. So
That is also
ABC is
important.
important. If the child is bleeding, please give platelets. Don't shift him without stabilizing the child. See that he reaches the center safely. And other thing is that if he is just hemoglobin 7, 8, not in a cardiovascular compromise, don't transfuse. Because if the count is high, more than 50,000, 1 lakh, just a transfusion may cause bleeding or thrombosis, and you may lose him in transport only. So a child who is very, very 80% chance that he's going to get better, you may lose in the acute phase. So these are all minor things.
And
So
I think the
better to
other thing,
referral, yeah.
transferring a suspected leukemic child is never an emergency. There is
Yes.
no need to diagnose leukemia today. It can wait for 5 days. There's nothing wrong. What is important is if he's in failure, transfuse him. But then be
Yes.
prepared to send him in next 1 or 2 days. The bone marrow is not going to
Yes.
change in 2-3 days time. So that's not a worry. Second, don't give steroids. So giving Efcorlin and Avil during transfusion is a
Not
complete
done.
no-no.
Not done.
Giving Lasix, completely no. That is not required. Second, for some reason you have to transfuse and it's going to take 2-3 days, at least collect peripheral smears before transfusion and send them along. We can even stain those peripheral smears and diagnose that they were blasts. That's second. Third, child is having high fever, sick, etc. Start antibiotic, take blood culture.
Yeah.
He's
Because
bleeding
he's
at
like a febrile
Viva said.
neutropenia.
Give
Though
platelets.
the count is to 50,000, but his neutrophils are 0. So he's like a febrile neutropenia. You should
Right.
give antibiotics.
Right. So all this, and once he's stable, send him
Yes.
along with either the liquid marrow or the peripheral smears or whatever you have collected, then send the patient. But don't wait for 1 or 2 weeks.
Yes.
Because many times what happens, your transfuse given 3 transfusion, hemoglobin is 11. And you're given antibody, the fever disappears. The platelets were anyway, they were not very low, like say 50,000. Patients say, "Abhi acha, I'm going home."
Oh, acha, yeah. The
Come
parents
after
will
3
happily
weeks.
take him home into his village.
And
So
we're
it's a
seeing this
delicate
type
balance
patients.
that
Yeah,
what one
very
should not
Yes,
do
delicate.
and what
yes.
one should do. Rather,
Yeah,
the life is
exactly.
also
I
important.
really believe in the pediatrician consulted partnership. I think this is really a role where a partnering is the best thing.
Correct.
Now, Nitin bhai,
Yes.
suppose if I get a patient of bleeding disorder, then which
Correct.
bleeding profile I should subject to?
Correct. So generally, a screening test and there are confirmatory tests. So if someone who has got bleeding, first of all, ask is it significant bleeding and is it a local cause of bleeding? So just an epistaxis doesn't need too many investigations. Maybe a CBC, normal platelet, always bleeding from the same side of the nostril, always right side. Then that's the local cause. Okay, or a newborn is a cephalometoma because you had a prolonged labor. Then that's not bleeding disorder. But if you have a true bleeding disorder, like he's having multi-site bleeding, recurrent bleeding, bleeding at unusual site, or bleeding which is exsanguinating, etc., you have read about hemophilia, ITP, or something like that. Then the basic bleeding profile that you do is you do a CBC for platelets. You see a smear for the platelet size and the shape. You do a prothrombin time and an activated partial thromboplastin time, that is PT, APTT. If available, then you also do a thrombin time and you do a serum fibrinogen and a factor 13. That will complete the bleeding profile screening test. And based on what you get, you interpret. But if you don't get all this, even a CBC, PT, PTT, and a thrombin time is enough. And then based on what you get, you can do further tests.
Right.
But doing BTCT is completely no. There is no additional value of a bleeding time or a clotting time. Clotting time has to be grossly abnormal to be evident on a tube method or on a capillary method. So it's too late. And bleeding time in a child with low platelet, you know is going to be high. You give a scar and the scar will keep on bleeding. It will lead to a bad scar at the injury site. So don't do this type of investigation in a patient with low platelet. So BTCT is no. So it's surgeon's favorite, but not for us to do.
Now, Vibha ma'am, as Nitin bhai said that no role of BTCT, but when PT or APTT, they are borderline high, then
So
at that time
basically,
any...
this is a really, because basically here, your history is very important. If you have taken the right history, there is no consanguinity, no history of bleeding, no past, there are natural challenges to a patient's bleeding profile. So if the child is now 5-year-old, he's fallen down so many times, he's had so many vaccinations, he's never bled. He's had tooth extractions or teething, he's never bled. So you know that this child has been challenged and he stood up to the challenge. So it is unlikely that he has a bleeding disorder. But your reports are not looking like, they are looking prolonged. So here you should worry that there is some factor. These are extraneous factors which are causing abnormal mild prolongation of both. Now what happens is that mostly now there are these big labs which have their central labs and they have many peripheral collection centers. So you ask for a BTCT, you send to a very famous corporate lab. The blood is collected there, sent to the main lab. I don't know how many hours it takes, and then there it is done. So that is the main cause of your abnormal prolonged PT, APTT. Other things are that if your sample is not collected properly, it is lipemic or it is hemolyzed, so then the optical thing becomes wrong, and then it shows a prolonged this thing. So if you come with that situation, you're sure that the patient doesn't have a bleeding disorder, just repeat it at a lab where it will be done immediately and in the right way, to a lab that you know that it is done perfectly. So these are the extraneous causes. Other thing is that if the sample has been collected from a central line, in an ICU situation, central line which is heparinized, so that will again your APGT will come prolonged. So these are small situations. Then there are some rarer situations in a neonate where the hematocrit is very high. So again, the plasma is less. So it will be erroneously prolonged. And you have to also know that the neonates till 6 months of ages have a different normal. Their PT is maybe up to 60 is also normal, but they don't bleed. So that also we have to know that for a neonate, 1.4 INR, a PT of 17, a PTT of 40 may be normal.
I'll just add to say that your citrate to blood ratio is very important. That's why I never
Yes,
put
9:1.
more blood. It should be 9:1. And number two, if suppose for some reason the lab is not able to do it immediately, they're supposed to centrifuge, remove the plasma and keep it in the room, in the refrigerator. And when the transporting is done, it should be on ice packs. Now, these three things are not looked into, as very rightly said, from the periphery to the central lab. So I would always prefer PT-PTK in a lab where they're doing it right there. Absolutely. Like say I send to Hinduja is going to do in the next half an hour. Whereas as compared to a collection center where God knows who is collecting what.
Now, Nitin, what about...
but I am happy if this happens. I mean, jokingly, because these patients keep on coming pre-surgical. Surgeon has done PT-PTT. It is high, Dr. Shako dikao. I say, okay, repeat it. Hinduja, normal. Okay, I get my consultation fee.
Now, Nitin, joke apart, what about platelet function studies?
Correct. So that's a very specific test. So when we do suspect platelet functional disorder, and then which test to do? I think these are two important. Any patient who has got a platelet type bleeding. What is a platelet type bleeding? Superficial bleeding, superficial ecchymosis, mainly petechiae and mainly epistaxis. Okay, very rarely huge hematomas, and never say a joint hemarthrosis or a huge muscle hematoma, etc., which is typical of a coagulation disorder, right? Yes. So once you have suspected platelet type of bleeding, then you do your CBC and a platelet count. Your platelet count comes normal, CBC comes normal. That fellow is repeatedly bleeding from, say, sometimes little hemorrhage from nose, sometimes from mouth, sometimes he had passed little blood in the stool, sometimes vomited with blood. These are superficial bleed, and now you are worried. So first thing you do, look at the peripheral smear. You see platelets which are very large. Then it's like Bernard-Schiller syndrome. You see platelets which are small but not in aggregation anywhere at all. What you call starry sky appearance. This is likely to be some receptor defect and a Glanzmann's like thrombocytopenia. Now these are the type where you will diagnose by doing platelet function studies. So there are two ways. One, you can do a platelet aggregation study, which is like a gross, which tells you about everything. And if one of them comes abnormal, then you will ask for a specific Glanzmann's or Bernard-Schiller by doing the receptor analysis. So these are the tests that you do for platelet functional disorders.
Okay. Vibha, a healthy newborn, many times it happens that it
little louder, Ramesh bhai.
Healthy newborn coming on day 15 with bleeding, then how will you proceed?
Yes, the first thing is that whether he is healthy or sick. So healthy newborn on day 15, if he comes with bleeding, and the bleeding is very classical, like a GI bleed, or sometimes very serious intracranial bleeds, then you will suspect a vitamin K dependent bleeding. or what was usually known as a hemorrhagic disease of the newborn. So newborns, they have very low vitamin K levels. So the transfer from the mother to baby vitamin K is not very good. And they don't have their own vitamin K because their intestinal flora has not yet developed. So these children might just bleed. Universally, all newborns need to be given vitamin K at birth. So I hope this is being followed and not missed. But suppose this child has not received that, then he may be prone for a HD vitamin K dependent bleeding. So these are the children who will come in maybe after the first week of life, and they will come with bleeding. So what you do is, as sir has rightly said, you do a CBC, look at platelets. Platelets are normal, do a PT, APTT. Both will be prolonged because vitamin K dependent factors are factor 2, 7, 9, and 10. So you will have all the three arms. So you have 2, 7, 9, and 10. So you have the extrinsic arm, which is 7. You have the common arm, which is 2 and 10. And you have factor 9, which is the intrinsic. So both your PT and APTT will be prolonged. So that is how you suspect that this is vitamin K dependent bleeding. And you treat it like that. So that is the commonest cause of a neonate coming with bleeding. If you get a late disease, suppose vitamin K dependent bleeding can come as late as 6 months. So these are then the secondary causes. In these cases, rule out secondary disorders. For example, a cholestatic disorder of the liver may first present to you with bleeding. You will first come to a hematologist, and then probably you'll have to look into his liver function. So that way, we have diagnosed almost about 2-3 neonates, which were, we picked up little abnormal liver functions, and then we found that they have this paucity of bile duct, that kind of disorder, and they were treated like that. And sometimes you have very early bleeding within 24 hours that can be really very disastrous. These are the children, babies whose mothers are maybe on anti-epileptic drugs or AKT drugs. So these mothers, if they are already like that, we have to preempt, give the mother vitamin K in the last few weeks of pregnancy before delivery. So that's the...
So at any age, a newborn comes who has not been given vitamin K, it should be given.
It should be given.
And
then
treatment... periphery, what happens that many of the times the parents straight away go home from gynec's clinic and don't show to pediatrician. So suppose if baby comes to me after 15 days, then also I should give first.
Yes. Up to 3 months, 6 months, whenever they
because
come,
it can be very bad.
Yeah.
Even before you do the test, you should give the vitamin K because it can be disastrous.
Yeah, and one thing, when you have this preterm with hemorrhagic disease of newborn, remember to give them also FFV because their liver may be immature, not even to respond to vitamin K.
Yes.
Number 2, if you have any bleeding child, even older child, you have to arrest the bleeding by FFP, especially the intracranial bleed. And lastly, you are just given vitamin K, you repeat your PT-PTT after 24 to 48 hours. It should become corrected. It doesn't get corrected, that means there is something wrong. There may be a common factor deficiency like factor 10. So 3 things are important: treat and also follow up and see that their bleeding profile has become normal.
Now, Nitin, in a suspected case of HDNB, who comes with vitamin K given 24 hours back, and now PT, APTT are normal.
Okay.
So how do you say?
So
it was HDNB or something else.
Correct. So this is typically what happens, like suppose there's a child 15 days old. Now he suddenly became pale and started bleeding, and someone gave vitamin K without doing PT-PTK. Okay. And now you find that there is intracranial bleed. He refers to higher center. Higher center does a PT-PTK. Next day it comes normal. Parents want to know what happened. So you can do PIVKA. PIVKA are the proteins which are induced in absence of vitamin K. Now, your PT-PTK will get corrected within 24 hours after vitamin K, but the PIVKA will remain high for next 3 to 4 days, even up to 5 days. So if you do a PIVKA, if it's high, then you can tell the parent that there was vitamin K deficiency, which anyway is corrected by vitamin K. Now, whatever damage is there, we need to correct that and follow up the child and help him from the further that point of view. So PIVKA becomes important in such issue where they have already given vitamin K before a prior PT-PTK, which was shown to be abnormal.
Very interesting. Now, Vibha ma'am, a child nowadays with prolonged hospitalization, we come across DVT. So in a suspected DVT, what prothrombotic workup you would like to do?
So, we are now going into this thing of thrombosis. So in thrombosis, we must remember that always there are multiple factors. So if you have a child who has unprovoked thrombosis, that is when I will go for further test. First and foremost, we have to understand if it is a secondary thing. If this is a child in whom you've put a central line which has been there for some time, or who is with sepsis, or who has been immobilized due to whatever surgery or some orthopedic surgery, or he's a child with nephrotic syndrome, or he has some cardiac. So these are all secondary factors. And if you find a cause like that, I would wait before doing, because these all thrombophilia tests are really very costly, and they are not one or two, there are 10 tests. But if you find an unprovoked thrombosis, if there is a family history of early deaths due to myocardial infarctions or strokes, or if you find that this is a second episode of thrombosis, then I will surely go ahead and do some tests. And then there is a whole battery of tests. So you can divide the causes of thrombosis into congenital and acquired. So congenital is you will have your antithrombin 3, protein C, protein S deficiency, or you can have mutations like your factor 5 laden mutations, which is where there is resistance to your activated protein C. And then you will have mutations in your prothrombin molecule. So these are all the inherited factors. Or rarely you may have hyperhomocystinemia. So the inherited type of hyperhomocystinemia, there they will come with very, very bad thrombosis. And then you have your acquired causes. So acquired causes also you can have hyperhomocystinemia due to MTHFR mutations and due to vitamin B12 deficiencies. Then you have your autoimmune disorders where you will do your APLA. APLA is your lupus anticoagulant, your anticardiolipin antibodies. So those are the tests. One thing I want to point out that iron deficiency anemia in infant is also a prothrombotic condition. So something simple like iron deficiency is a prothrombotic condition. So we need to recognize that and treat it. And then there are many, these are all the tests which you do. Not to forget our simple sickle test. So that is the first thing we have to do. You have to do a 2D echo first if there is any cardiac condition. So these are all the tests that we need to do. And we must remember that in the acute setting of thrombosis, you should wait for some tests, and some tests can be done. For example, you've had a thrombosis, and if you do your protein C, protein S, antithrombin 3, these are assays. So they are consumed in a thrombus. So if you do a test, immediately they will come low. So you will not be able to interpret which are they really, really low, or they are low because they have been consumed. So actually, I would rather save money and do them at a later date, because your management is not going to change. You are going to give him anticoagulant, you have to give him, irrespective of whatever. But some tests you can do. For example, all your mutation studies, MTHFR, factor 5 leading, these are the tests you can go ahead and do at any point of time. So you have to weigh the risk, follow this child up, treat, and then go ahead.
So just to add that, we also found that factor 8 levels, if they're high, there's a very, again, it's common in Indians, so 150% and all. So that's another story. And lastly, don't forget to triglycerides. Many children have hypertriglyceridemia, they may have thromboembolism. But remember, this package costs 25 to 35,000, depending on where you do it. So
exactly.
I mean, be careful.
You have to really think whether you really want to do.
If you have someone who has done an umbilical catheterization or a femoral line catheterization, central lines, ports, a central in the neck, and then you will find that, or someone who's dehydrated and has a thrombosis, wait, just treat them, wait for 3 to 6 months. There is no hurry.
Exactly.
Right.
Now, most of the times you find secondary causes.
Yes. Now, Nitin bhai, during COVID times, the most abused investigation was D-dimer, and most abused medicine was azithromycin. So how does this D-dimer helps?
Correct. So D-dimer is a degradation product of fibrinogen. So initially we should do FDP, the fibrinogen degradation product. So basically these are all tell you that there has been a microthrombi or a microvascular thrombi, which the thrombi are getting dissolved, and that's leading to high D-dimer. So typically this is seen in DIC. So D-dimer is a good test to rule out DIC. Suppose you have a patient who has got a DIC like picture, and his PT become normal. Now he may be stable DIC where the PT is normal. It's like how you have a high output failure, but you may still have a normal cardiac function because there is compensation. So this is compensated DIC as we call, but the D-dimer will be high. So D-dimer is a good test to rule out DIC. And
it's got a very good negative predictive value. If it comes normal, you are sure that there is.
Hundreds of causes for DIC, depending on your clinical feature. So if you suspect DIC, do D-dimer. If it's high, then you know that's the cause of all your wounds. And then you follow them up over the time.
Any comments on some specialized test जिसके हमें नाम भी इनफेक्ट नहीं आते?
Like
What
no,
new new test you mean?
So beyond this, all these tests, we have 2-3 tests. Like you have very famous, as I said, is the NGS, the next generation sequencing. So we started with exome, then clinical exome, now whole exome, and so from starting of 40,000, it has come down to 10,000. People come with that report, and if you do an NGS in a normal people, you will always found 2-3 mutation which have no value at all. So they are mutation of so variants of unknown significance.
Unknown
So if you
significance.
have VUS, then the pediatrician gets stuck. Abhi is a cause or no, then he refers with the report. So we should really refrain just because it's
Yeah.
available from doing, because if you do a blind test, you are more confused sometimes than you are actually helped. But yes, in a specific condition, it is helpful. So all
Yes.
genetic disorders, you can do a next generation sequencing, or an unknown patient where you've done most of the routine tests and you still don't find a cause of, say, hemolytic anemia or something which is genetic, multi-organ, etc. Then you do. And remember, all genetic tests are not picked up on NGS. Sanger sequencing is the way to go. You can't do Sanger sequencing for every disease. Number two, always do trio. You do childs. If it comes abnormal, ESC homozygous for some mutation, both these mutation, one should be in the father, one should be in the mother. If that's not there, then something is wrong with that testing. Number three, so you do Sanger sequencing in the parents and the child and confirm this is not a pseudogene. Lastly, remember, mitochondrial disorders are not picked up on normal NGS unless you told them that you also want mitochondrial gene sequencing. So there are ways and means. I think this is best left to the specialist to order this type of test, and not just because they are available at dime a dozen now with 6 laboratories pitching in with every pediatrician कि हम 10,000 में करके दे देंगे.
Even large deletions are not picked up. So
yeah, large deletion will not be picked up.
Will not be picked
Chromosomal
up.
disturbance
So
will not be picked up.
basically, I think pediatricians defining the phenotype is very important before you do the gene. Phenotype, even
copy variants will not be
clinical
picked up.
and even your basic tests. First you define the phenotype, then only genotype will be helpful.
And as Viva said, I had a patient of sickle cell anemia who would come with an NGS report.
Yeah.
All you need to do was electrophoresis, which costs 500 rupees, and an NGS which costs 15,000.
So how are you going to justify such a cost to the parents? You said, "Abhi 20,000 spend kiya. What is the report? What are you going to say?"
It is in thing now because it is costly.
Yes.
Now, Nitin, by recurrent infections, many of us we get. So primary immunodeficiency screening.
Correct.
Vibha ma'am, can you?
So basically, PID screening, again, clinical history and examination is very important. So you have a proper, I think Nelson is also giving a proper algorithm in which babies, children, you need to screen for PID. So after having done that, you're sure you want to go ahead. First, a CBC and a peripheral smear is always very important, because something like a Viscott Aldrich will be just suspected and picked up on a peripheral smear. You find very, very tiny platelets. So going ahead with that, you do immunoglobulin levels, you do a lymphocyte subset analysis. So wherein you do all your, the lymphocyte subsets, that your B cells, your T cells, and then all your variety of T cells, your T helper, T suppressor, T naive, then your NK cells. After having looked at all that, then you do test for, say, if you're suspecting a chronic granulomatous disease, then you do a DHR assay, dihydrorhodamine assay. Then if you're suspecting a leukocyte addition defect, you do a flow cytometry. So these are all the tests which will define the phenotype. But here again, I will say now the repertoire of PID has gone to almost 400 disease and counting. We are still counting. So here is where if you strongly suspect PID and you're not able to pin it down, you may take the help of whole exome after giving a good phenotype to your geneticists. And remember that now no longer it is known as a PID. It is known as inborn errors of immunity. But not just infectious diseases, but your autoimmunities also come into these pictures, and then also some cancers. So it's a triad of cancers, autoimmunity, and PID. Immunodeficiency. So these, if you suspect these, then you have to go ahead for these tests.
And a group of autoinflammatory disorders, which are inborn errors of innate immunity, not only adaptive, but innate.
Yeah.
That is coming in a big way. I mean, it's
Yes.
a
So
expanding and very, what do you call,
very
interesting field.
interesting
When you
field.
read it,
Very
you keep on
interesting
going in
field.
depth, but at the end, your hard disk gets completely corrupted.
So the youngsters
So
have got a
basically,
better field.
now
Yeah.
hematologist, immunologist, your rheumatologist, all allergy, all are coming into one field now. There is a
Yes.
big gray zone. There is no
Correct.
definition now.
Correct.
So I'm so happy that we have covered all the questions right on the time, and coming now to the last question. Then we'll take up the questions which have already we got in WhatsApp, and
Correct.
then
Please.
what we got in
Let's have
the
rapid
session.
fire.
So double negative T cells finally.
So
Correct. So double
double
negative. Normally,
so,
your lymphocytes are CD4 or CD8 positive.
yes.
If both are negative, they are either the very precursor, which normally are not seen in the periphery, or they are the old cell which should die off. So if the double negative population is around 1 to 2%, if it become more, then it leads to autoimmunity and what condition we call autoimmune lymphoproliferative syndrome or ALPS. So DNT is a screening test to rule out ALPS. If you have 5% DNT, then you need to do further workup for ALPS.
Yes.
Great. Now, a few of the questions which we already got on WhatsApp. Clinical significance of delta bilirubin in neonatal jaundice. Any one of can any of you?
Delta bilirubin is what is bilirubin bound to albumin. So it's neither direct bilirubin nor indirect bilirubin. It's the third bilirubin which is bound to albumin. So in a patient with neonatal jaundice, because of liver disorder, the bilirubin will bind to the albumin, and that will be known as delta bilirubin. So you take total bilirubin minus direct and indirect, what component remains is delta bilirubin. If it's high, it suggests that there is cholestasis in this baby. I mean, that's all it tells you.
Right. Then in sick, particularly admitted child, how frequently CBC should be repeated? CBC.
Viva?
I mean, depends. Yes,
So that depends. It depends on the situation. What is the cause of sickness? For example, if it's a dengue fever, you may need to repeat at least alternate day till the child is turning the corner. If it is a ITP, if you may need to do it depending on the child's bleeding. If you have given the steroids, if he's settling down, you can wait for 48 hours and then a week and then once a month. So something like that. So it depends on what the situation is. If it's a typhoid fever, you have the child and you have the fever to look at, then why do the CBCs? It's not going to help you at all. So again, similarly in malaria, you don't, because in malaria, the platelet is never going to fall so low that the child is going to bleed, even if it is low to begin with. The child is responding, you don't need to do CBCs.
I think we need to ask this question also to the parents, because many times they keep on doing tests and come with a report rather than we asking for it.
Now, 7-month-old child, fever of 2 to 3 days with CBC shows polymorphonuclear leukocytosis. Shall we consider stress or sepsis? I mean, so how to differentiate between stress or sepsis hematologically? One wants to ask.
Between what?
Stress and sepsis. I was really
Sepsis. I mean, 7-month-old child with leukocytosis, which is neutrophilic, I would worry about infection, which is bacterial, especially urinary tract infection, because it may not have any symptom in such a small child. The least I would do is a CRP and a urine routine. If urine routine shows more than 10 to 15 pus cells, I would definitely do a urine culture and then only treat with antibiotics.
Yes. Now, when should we start iron in preterm and term babies, and how long to continue?
So preterm, you should start extreme preterm at the time of discharge when they are stable. Otherwise, preterm when they double the birth weight. So that's around 4 to 8 weeks. And in a full term, again, when they double the birth weight, which is around 4 to 5 months.
4 months.
The national program says from 6 months. I would say from 4 to 5
4
months.
months, exactly.
And what dose?
At 1 mg per kg.
So preterm 2 mg per kg, full term 1 mg per
1
kg.
mg
That is elemental iron per day.
And iron alone or with folic acid and vitamin?
No, iron alone is okay, but our national
There
program
are
says iron with folic acid.
And there are no preparations.
No preparation, absolutely.
Right.
So IFA tablets, iron folic acid tablet.
Yes.
There is a
commercially available syrups also have folic acid.
Yeah, correct.
Most commonly asked question, which molecule?
I prefer iron ascorbate, and I'm being very truthful. I only use iron ascorbate. I don't know about Viva. She may be using fumarate.
I'm very whatever is available. So syrup form, I use ferrous fumarate.
Correct.
And drops are not there. No drops are ferrous fumarate. So they're ferrous ascorbate, and I have good results for both.
Correct.
So basically ferrous followed by whatever. Ferrous is very important, and a good amount of elemental iron, not even very high.
Yeah. The other thing is do not exceed the dose. It's not required, because extra iron leads to side effect. Yes. And now we know that iron is not only required by humans but also by the microbiota which is in your gut, you give too much of iron, it leads to growth of unnecessarily iron-dependent microbiota, which may not be your friends, and that can lead to more disturbance. So that's why you see many children get diarrhea and all GI disturbance is because of that. So don't give extra. The consensus statement of IAP, which has been recently published, says 3 mg per kg as therapeutic is more than enough. So you can imagine prophylactic will be even 1 mg per kg. Sometimes you may even give twice a week instead of giving daily.
Right. Now, about CRP, Nitin bhai, a couple of days back on the webinar, it was informed that roughly less than 10, it could be viral, more than 40, 50, it could be bacterial, and in between, it could be viral or bacterial. So, any cutoff or?
So, if you actually look at the trial done by Synthorix in their COMPASS study, they took cutoff of 40. So, they were said the B cap, that is probable bacterial community acquired pneumonia, B cap, was if someone had X-ray changes with CRP of more than 40. So, I think that's sensible. But that's not sacrosanct. You can have a viral also having 80. So ultimately, CRP is only one of the guiding force, not the real diagnostic criteria per se.
So more of a prognostic.
Yeah, procalcitonin is more specific, but it's extremely expensive. So you
now
normally don't do it beyond
CRP
ICUs.
versus PCT.
Yeah, so PCT is mainly for ICU patient rather than for normal patient. If you make them spend so much, they'll run away from you.
Nitin, best method for blood culture collection is while putting fresh IV cannula or direct vein puncture.
No, so you should, for blood culture, it should be a separate. When you're putting cannula, also you can do it if it's first time cannula, but don't collect it from an already existing line. If you're collecting from central and ears, then you have to discard the first 3 to 5 ml of blood. And when you collect from a central, it's a surgical procedure. You have to clean the whole thing with 3 swabs around the wound side with complete gloves and like a surgeon wearing a mask and everything, and then collect because it's a very sensitive way. Otherwise, you can have contamination.
And the volume of the blood collected is very important. Some you collect very less and then you say that the culture.
You should not exceed also. Like suppose your PET bottle is around 2 to 8 ml. Adult bottles are 15 ml. So you should not exceed. If you put more also, it will
basically
not work.
They say, sir, I don't know if I'm correct, 1% of the total volume of blood.
But that depends on which bottle you say. If you're using PET bottle, pediatric bottle, then it's only 2 to 8 ml. So you don't collect more than 5 ml. Sometimes it's difficult to collect 5 ml.
Yes, exactly.
Now before surgery, surgeons they ask for BT-CT. So how rational it is?
Waste paper basket tests. No value at all.
It's very, very bad. BT, if the surgeons ask, we should tell them that it's very painful.
CBC, PT, PTT is a standard pre-operative in a otherwise asymptomatic person. Absolutely. And why would you do it? Because mild hemophilia may bleed only during surgery. That's the reason why you will do it even when there is absence of any history in the past.
Okay. Now, PT, APTT sample, can we keep overnight and send in morning? Is it okay or only fresh sample?
So you have to spin the plasma and store it at 2 to 8 degree. Then you can do it later. Like suppose I have a hemophilic patient, right? And I ask for factor 8 level in my laboratory, like say in Hinduja. How they do it? They have stored hemophilia plasma at minus 80 degree. They will thaw it and use it as a control. But that means the laboratory can do it. You can't do it in your fridge. And you can't give the blood without spinning for more than, like you should do the test within half an hour to 1 hour. Otherwise, spin it and remove the plasma and put that plasma in the refrigerator.
So it is better.
Same things happen if the patients come in emergency and you need to treat them. You need to give them factor 8 or FFP. Right. Then in that case, you collect the sample, send it to the lab. Tell them to store it in the, don't keep in the ward or your fridge.
And you know, suppose I have a patient who is bleeding disorder suspected. I tell them kindly do PT, APTT and please keep sample for further studies. So what they'll do is they'll do a PT, PTT and the PTT is prolonged. That is his hemophilia. Then they would have frozen the plasma. Then I'll ask, okay, do first factor 8. If that comes normal, then do factor 9. If that comes normal, then do factor 12. Like that.
Yeah. Now, leukemoid reaction, something about leukemoid reaction. Can you?
Viva?
So, leukemoid reaction is basically there is increase in the total WBC count. So there can be a lymphoid leukemoid reaction and a myeloid leukemoid reaction. So when the lymphocytes increase, so when you see a morphology, if it is a non-clonal, so if you see lymphocytes, increase in lymphocytes in all, they look morphologically different. So that is a leukemoid reaction. Whereas if you have a leukemia, then it's a clonal disorder. So all lymphocytes look same and they are blasts. So that is the other way to differentiate. Initially, it was by doing a lab test. So LAP. So lab test would be normal in a leukemia, whereas high in a leukemia reaction. So that's how it is. But morphologists will be able to tell you something like a whooping cough and all. It is seen a very high.
The other thing, when you have myeloid leukemia reaction, you'll see cells of each immature series. You'll have metamyelocyte, myelocyte, neutrophil, and you may
all
see
thrown
some.
into the.
Whereas in leukemia, there's a window. It's blast and neutrophil, nothing in between.
Yes.
So we have discussed this thing, but still someone has asked best single lab test for diagnosis of anemia.
Of anemia, CBC and a peripheral smear and a retic count. These are the three things you must do in an anemic patient.
Right. A role of B12.
And the best, the best test for iron deficiency is iron therapeutic challenge test. You have anemia, you have nothing, just put them on oral iron 3 mg per kg, repeat hemoglobin at 1 month and 3 months. By 3 months, the hemoglobin become normal. You have treated iron deficiency without doing any tests.
And even if your hemoglobin is 3, don't transfuse. They will become better on iron.
Absolutely.
Avoid transfusion.
That is very important advice. Now, why they ask for fasting sample, particularly in thyroid lipid profile hormone assay?
Because in a baby who is fed milk, the lipemia of the milk will interfere with coagulation tests, TSA, T4, so many tests. That's why in a small baby who is on predominantly milk feed, they want a fasting sample.
Right. Can a sickle cell disease or trait child have malaria?
Can die of malaria?
No, of can child have malaria? Can child
they can, of course, have malaria.
So they are asking because it is a
malaria
thing
belt.
Malaria belt.
Yeah, so it is, the incidence is less, but it is not that they can't get it.
They cannot have.
And similarly, how to treat G6 PD deficiency child with P-Vivax malaria?
So chloroquine is safe, but you don't give primaquine. But if you want to give primaquine, then you have to be worried about the dose. It should be not the full dose. It should be 1/3 the dose and only once a week. And that too under supervision, that there is no hemolysis.
Right. Then so many friends, they have asked for a role of injectable iron. So indication and dose of iron sucrose in iron deficiency anemia.
So first of all, I have stopped using iron sucrose because now iron polymaltose also is allowed. So ferromaltose, which is available for adults, is now a total dose iron. So you calculate 4 into weight in kg into the hemoglobin difference that you want rise between the ideal and the patient. And you can give it at one go. So iron sucrose is what we used to use in past, fractionated dose, not more than 4 mg per kg per day and such once a week. So suppose the child is 10 kilo, hemoglobin is 5 gram, you want to raise to 12, so difference is 7. 7 into 4 is 28, into 10 is 280 milligram. So you, 10 kilo child can take only 40 or 50, so you'll have to give 5 times every week, 5 weeks. Whereas the carboxy maltose, you can give all 280 at one go. The only indication is true intolerance. You keep on writing, the child just doesn't take, or the patient doesn't take. Number 2, the loss of hemoglobin is more than what can be done by oral absorption, like in a typical GI bleed or multiple polyposis. Third, if you're giving someone erythropoietin, like chronic renal failure patient, they can never be compensated by giving oral iron. Same when you give EPO to a preterm child. Nowadays, we don't use, but otherwise they need it. And lastly, there are certain conditions where there is malabsorption. Like suppose there is a short bowel, tropical sprue, or a celiac till the time his diet is controlled and the villi are back. These are the only indication where you give actually IV iron. But in a iron deficiency where you are frustrated, the patients keep on coming back, they are not taking properly, it might be a bad idea to call them in OPD, give them in under supervision, keep them for 1 hour and send them home.
One
and then even conditions with chronic autoimmune diseases,
inflammation.
There the inflammation because of the rise in hepcidin, they don't absorb iron. So you have to bypass that mechanism by giving IV iron.
So one friend had written this thing, that I do this thing in my practice, and with first dose of iron, generally child becomes better, and then the compliance is not a problem. Nitin, what would be the optimum time to check the response to oral iron therapy, Dr. Jain Joshi?
So on 5th to 7th day, you can see a reticulocytosis. At 1 month, you should have at least 1 to 1.5 gram rise in hemoglobin than the baseline. And by 3 months, almost normal hemoglobin. And then you continue iron for another 2 months to replenish the stores. That's the typical treatment of iron deficiency.
And what we learned during our residency days, that within 24 hours, you can see the mood change.
So there is a feeling of well-being in first 2-3 days. That's there.
The mother will say that happens. Iron
Child is less
deficiency is the most
irritable.
rewarding thing to treat.
Yeah, child is less irritable. He wants to eat now, doesn't cling to her all the time, etc.
Right, right. So
And of course, iron deficient treatment is not only iron supplementation. It is deworming, diet modification, stopping the bottle, and overall improvement in everything, including hygiene.
yes, comprehensive. Now, I think Dr. Sanjay Deshmukh has asked that in the era of availability of HPLC in government setup, should cycling test continued as screening test in ANC patients?
So cyclic screening, yes, is the best way to diagnose in a. Suppose you are working in say Chhattisgarh, where there is 8% population which is with sickle cell trait. Then you can't keep on doing electrophoresis everyone. First do cycling test. If it's positive, then you do further test. If it's negative, leave him alone.
Yeah.
Now,
It's a good
regarding this
test.
dietary habits, vegetarian and non-vegetarian. So, what is the incidence of B12 deficiency in pure veg people? I mean, is it so that veg people they have got more chances of vitamin B12 deficiency? Some say that fresh milk
No
immediately.
fresh milk, please. It has to be
Brucellosis.
pasteurized and boiled. But if the vegetarian people are taking milk and milk products, then I don't think they
Yeah.
have a problem.
So
If they are
pasteurization
veganism,
doesn't destroy B12.
yeah.
Cooking food destroys B12. Boiling milk at 100 degree like on a gas destroys B12. The only source of B12 for such family was contaminated water, whether you like it or no. But today's water supply is so pure. That's why you see suddenly B12 deficiency is so common. And people who have the methylene tetrahydrofolate detector enzyme the mutation heterozygous, not homozygous, so will have
Homozygous.
hyperhomocystinemia. But heterozygous is 1% in Gujarati community, and they have requirement of high B12 because their homocysteine levels are very high.
So other thing is eating gutka. These young adults, especially in Gujarati Marwadi community, they
Oh
eat
my.
gutka. It chelates the iron, B12,
Ah,
everything.
correct.
So these
Now,
are the
Nitin bhai,
typical people. They will come with B12 deficiency. Young people.
Nitin bhai, any typical presentation in CBC, in peripheral smear, in hemophilia patients?
So they will have low hemoglobin, high MCV, they will have hypercephalin neutrophil, not a very classical Megaloblastic, but subtle, and they will have hyperpigmented knuckles. And they are always little unwell, and the MCV is always 90, 95. You treat them, and there is a tremendous feeling of well-being.
Right.
And homocysteine will come down. That's the most important thing.
Then Dr. Muthurama has asked that in
Little louder, Ramesh bhai, I can't
and
hear
in
you.
primary leptomeningeal lymphoma, kindly mention about lab test to do to approach to diagnose primary leptomeningeal lymphoma. Any test for?
Never seen one in children. It's more in adults and in HIV infected people.
HIV,
Primary
yeah.
brain lymphoma, actually, not
Yeah.
leptomeningeal. You can have leukemia with leptomeningeal, what do you call, seeding, and they may have no other symptom. We have had a patient who presented only as CNS leukemia. There was no peripheral leukemia. Bone marrow was normal. You do a CSF, it shows abnormal cell. So there you do CSF, it shows blast. You run flow, like how you run on a bone marrow. You run on the CSF.
So now coming to an end,
Yes.
it was a really a wonderful time management by both the speakers. We have finished not only our original webinar but questions also, which we got live as well as during our WhatsApp messages. So thank you very much, Master Blaster, Dr. Nitin Bhai, and equally supporting Dr. Vibha ma'am. I mean,
Thank you so much,
I hope
Dr.
all the
Ramesh.
friends they enjoyed it really, and this would be available as a recording link, which we'll later on share with the friends. Thank you
Thank you so much.
So
Thank you
Ramesh
so
bhai,
much
you will
for
agree with my first statement that the teacher feels proud when the student surpasses the teacher. So you have
sir,
seen a live
please,
example today.
not surpassing at all, not in this Janam, sir, maybe.
Okay, so before we close, we meet on 4th of April, which is the first Thursday of month of April. Very soon, in next 1 week, we will declare the faculty and the topic, and hope we will have the same type of response even in the next month. And
I
we
would like to
continue this
say
every
thank you, sir, Dr. Nitin Shah, sir, Dr. Ramesh, for letting me sharing a platform with sir.
No
Yes.
That is
My
such a
pleasure.
big this thing for me.
And thank
Pleasure.
you,
Yeah.
Zydus, for
Big
providing this,
pleasure.
Thank you.
platform.
Thank you,
Yeah, so
Zaidus.
yeah.
So,
So
Yeah.
I just wanted to highlight that this the whole recording will be there with us in next 2 days. I'll share the YouTube link so that the
Perfect.
people who have not attended they can also
Correct.
have the learning of
Okay.
the discussion.
Please send it so that we can put it in the group so
Sure.
that because there have been a lot of requests to me saying that we are unable to see, we want to see it later. It's okay, perfect.
Right.
We'll find, we'll do it.
Okay. Thank you, sir.
Thank
you,
All right.
everyone.
Good night,
Thank you
everyone.
so
Thank
much.
you,
Bye.
Ramesh
for
bhai.
this.
Good night,
Yes.
sir.
Thank
Bye,
you.
Bye,
Jen
sir.
bhai,
Good night.
Chetan
Good night,
bhai,
Nitin
Bye.
bhai.
Mahesh.
Bye. Good
Bye.
night.
Everyone is
Bye.
there.
Good night,
Bye,
all
bye.
Thank you
friends,
so
Alok.
those who
much.
attended.
Yes. Bye.
Nitin bhai, it is always a pleasure to listen to you.
Thank you,
I
sir.
think we
Thank you.
always learn everything at the end of it. And Vibha, you have been really great. I'm really proud of you.
Thank you,
Thanks a
Dr.
lot.
Joshi. Thank you
Thank you.
very much.
Always
Yeah.
a
Thank you
treat.
very much.
Thank
Treat.
you.
Yeah.
Yes, Jain bhai.
Yes.
All
Thank you
right.
Yes.
so
Thank
much.
you.
Thank
Thank
you.
you. Bye bye.
Thank you.
Yeah.
Bye,
Thank
everybody.
you.
Bye.
Thanks,
Good
Ramesh
night.
bhai. Thanks.
Good night.
Bye.
Thank you
Good
so
night.
much.
Bye.
Thank you.
Bye.